Hello, everyone, and welcome to the 50th Annual AAKP National Patient Meeting. I'm Erin, Deputy Director for AAKP. I've had the pleasure of working in the kidney space for over 20 years and the privilege of being part of this great organization for a little over 8 years. During that time, I've had the opportunity to work closely with AAKP's Executive Director, Diana Kleins, our board leadership, to launch two important initiatives: our Center for Patient Engagement and Advocacy, and our Center for Patient Research and Education. And I've also had the opportunity to stand up our organization's ambassador program. It's an honor to be part of this historic milestone of AAKP's as we celebrate the golden anniversary of this event. Our theme, 50 Proud Years of Patient Education, 50 Years of Saving Lives, 50 Years of Saving Livelihoods. It reflects both the extraordinary progress we've made, and the enduring mission that guides us. For 5 decades, AAKP has been committed to empowering patients, supporting innovation, and driving policy change in kidney care. This meeting is not only a celebration of our past, but also a look forward to the future we continue to build together. One of greater patient choice, stronger communities, and better outcomes for all impacted by kidney disease. Today, I'm pleased to introduce our session, Protecting Your Health and Livelihood, Infection Prevention, Reducing Risk in Everyday Life, sponsored proudly by CorMedix. I'd like to begin by introducing our outstanding session speakers. Joining us is Dr. Irfan Agha, a nephrologist and clinical researcher based in Dallas with over 2 decades of experience. He has contributed extensively to research on chronic kidney disease and dialysis management and is actively engaged with international nephrology societies advancing best practices worldwide. In addition to his clinical work, Dr. Agha is passionate about using technology, including artificial intelligence and data-driven approaches, to improve patient care and outcomes. Joining him is Dr. Rohan, Assistant Professor of Medicine in the Division of Nephrology at Washington University in St. Louis. His research focuses on improving outcomes for kidney transplant recipients, particularly those experiencing delayed graft function, and on expanding organ utilization to save more lives. Previously, he helped grow the transplant program at George Washington University, where he built a successful inpatient service and earned multiple teaching awards. To begin our session, please join me in welcoming Dr. Agha, who will start us off by discussing infection prevention in dialysis patients.
Thank you. Thank you for the very generous introduction, and thank you for the opportunity and the invitation. It's a pleasure to be here this afternoon. And on a point of personal privilege, it's a pleasure to be on this panel with Dr. Paul, who is at WashU, the university where I trained, my alma mater. So that's an added honor for me today. So I'm going to talk about infection in patients on dialysis, and I'll kind of build the scenario. This is going to be an informal talk. If you have questions, you can interrupt me. This is geared more towards patients with kidney disease, so I'm not going to go too much into specifics. It will be a general summation of what we deal with, what our patients deal with when they're dealing with advanced kidney disease. When we develop end-stage kidney disease, there are many different ways in which we replace kidney function. So kidney replacement therapy can be in the form of kidney transplantation, which is the best form of kidney replacement therapy. But dialysis, due to several constraining factors, is a necessary bridge in getting us from where we need kidney replacement therapy to where we can successfully transplant. There are several patients where transplantation is not possible due to various reasons, and in those cases, dialysis becomes destination therapy and not a bridge to transplantation. The big picture, When somebody's got advanced kidney disease and they need kidney replacement therapy, ideally we need to get them to transplant. If we can't, then we treat them with dialysis. There are some patients who are more appropriate candidates for conservative non-dialytic management of their end-stage kidney disease. Now, if we decide that we are going to do dialysis, then we can use what is known as hemodialysis, and I'll explain those in a little bit, or peritoneal dialysis. And hemodialysis can be in-center. So you've seen those dialysis centers, USRC and Fresenius and DaVita, where these are like storefronts. You go in there, there's dialysis machines, there's nurses, and a lot of patients come in and get their dialysis done. So that's in-center dialysis. Home hemodialysis is where you can actually have a machine placed in your house and you can do the dialysis yourself. There's another variety of home hemodialysis, which is known as staff-assisted home dialysis, where a dialysis nurse can come in and do your dialysis at home for you. Peritoneal dialysis, which employs one of our body cavities as the dialysis membrane, is done at home as well. So now let's take a look at what dialysis is, because this will start building the case to the risk profile of our patients when they are in need of renal replacement therapy, and why we need to pay attention to infection reduction in these patients. So on the left side, this cartoon shows a catheter which is kind of inserted into the belly. It sounds a little worse than it really is, but we use one of the belly membranes as the dialysis membrane. And so fluid is inserted inside the belly cavity, dialysis happens, and then we drain that fluid. So whenever something goes from the outside of the body to the inside of the body, there's always a chance of contamination and infection. And one of the concerns that we have with peritoneal dialysis, and we devote quite a bit of time to ameliorate that concern, is the risk of infection. So that's peritoneal dialysis at a very high level. There are various modalities and techniques of doing the peritoneal dialysis procedure, but it is generally done at home. Now, in contradistinction to peritoneal dialysis, where there's no blood being accessed, hemodialysis, hemo means blood, so blood dialysis is where we need access to the blood flow. So essentially, at a very high level, what we do is we take blood from the circulation and it is run over a dialyzer through a dialysis machine. That's where the dialysis process happens, and the cleansed blood is then returned into the body. So you can imagine, again, there's things poking from the outside to the inside, taking blood away, returning blood, and there's ample chance for contamination. So that starts building the risk profile of our patients and the things that we need to do to decrease those risks of infection. So this is the risk profile. You've got the patient in the center. There's individual risk. Patients develop end-stage kidney disease due to a reason. They may have diabetes, and diabetes after a long period of time decreases your ability to fight infection. They may have a glomerulonephritic process, an inflammatory disease of the kidney, for which we may have given them drugs that lower the ability of the immune system to fight infection. And so this then increases an individual risk towards catching infection. Then exposures are important. I told you that in-center dialysis, you go in and then you're getting dialysis. There are many other patients there getting dialysis, so there is some chance of cross-contamination and exposure. And general risk, as we age, as we grow, there are some age-related risk factors that predispose us to infection. So even if you don't have kidney disease, as you go into your 50s and 60s, you're recommended to get some vaccination. So those risks remain. But on top of that, if you're on hemodialysis, you get an enhanced risk because of access-related issues, and in dialysis parlance, access is the mechanism through which we gain purchase into the circulation, or we gain purchase into the peritoneal cavity to perform the dialysis procedure. Now, I told you that we take blood out and run it over a machine or over a dialyzer. It is dialyzing against a bunch of water. Liters and liters and liters of that clean water is used as dialysate to suck out the impurities from the blood. And that water is generated inside a water generation system in that hemodialysis operation. Now we go through great lengths to keep that water sterile, and it is a very pure supply of water that is allowed to touch your circulation, but that's where some risk resides as well. And then again, general environmental risk, blood dialysis in a hemodialysis unit. There could be contamination because of blood, there could be contamination because of machines. People with certain type of blood-borne viruses in their profile are dialyzed in isolation so that we don't cross-contaminate other patients. But all of these things constitute some risk towards infection in hemodialysis patients. And on the PD catheter side, the biggest risk is from that catheter sticking from the outside of the body inside the abdominal cavity. And we want to make sure that the catheter is always sterile, and we want to make sure that when we hook that catheter up, and that's mostly patients doing it themselves at home, and that's the biggest part of your training when you're undergoing training for peritoneal dialysis, how to make that connection in a sterile fashion. And again, having that fluid completely sterile at all times is important, because if the fluid is not sterile, then that's going to lead to problems. Like in everything else in medicine, the best way to treat is to prevent. And so what we want to do is to prepare the patient well, and then prepare the unit well, either the hemodialysis unit or the peritoneal dialysis unit. They need to have their procedures meticulously fine-tuned, and the patient needs to be built up to avoid and mitigate some of the risks that I'm talking about. And one of the most important things that we can do to avoid infection risk in dialysis patients is to optimize access. So there are different types of accesses that we use. So on the left side, we are looking at an arteriovenous fistula where your native artery is connected to a native vein, and so that vein becomes what we call arterialized. It becomes a little fatter, and it has enough flow that we can stick needles into it and get enough of a blood flow to run the dialysis procedure. Now, in the hierarchy of accesses, this is king, but it takes 3 or 4 months for this thing to mature once it's surgically created. Another way is we can, instead of connecting directly the artery to the vein, we can stick a little bit of a plastic tube in between the two and use that as a dialysis access, and this is in between. Unfortunately, if we are caught red-handed and are not ready for the dialysis procedure, then we have to put in a catheter in the neck, and this is an access of last resort if we're not ready to start dialysis, if for whatever reason we don't have an access in place. But then the infection risk for this type of catheter is very, very high. And so one of the biggest pushes that we have today is to reduce the catheter rate in our dialysis patients. And the way we can reduce this is by planning well. So you need to have all patients who are moving towards late-stage chronic kidney disease need to have this conversation with their nephrologist. What is the type of dialysis I'm going to do? I'm going to do peritoneal dialysis. I'm going to do hemodialysis. If it's hemodialysis, then at an appropriate time, they will recommend to create this fistula surgically so that when time comes to start dialysis, we're not sticking catheters in. If we start dialysis on a semi-urgent basis with a catheter, that increases your risk of hospitalization, risk of complication, and indeed risk of death in the first year after initiation of dialysis. So catheters should be a last resort, and we can sidestep this entire question of infection if we just had a proper access in place. Now, if we do have a catheter in place, then there are protocols that need to be meticulously followed inside the unit and by the patient to decrease chances of an infection. So water, I mentioned, is very important in the sense that if the water is contaminated, you can get an infection. So it is tested very, very frequently for the presence of bugs and other contaminants. The medical director of your dialysis unit would be reviewing that, signing off on it, and making sure that the water quality is absolutely A1. Once we have kind of started dialysis with the appropriate access and we have mitigated the risk of catheter-related bloodstream infections, we want to make sure that we are controlling the environment, right? So when somebody is being prepared for peritoneal dialysis, your peritoneal dialysis nurse will actually visit your house. And they will come in and see what the logistics are like, where the fluid will be stored, where the dialysis process would happen at night, where would the patient be making the connection, if there are other factors that they need to adjust. And so what they want to make sure is that we can provide the peritoneal dialysis in a clean, safe environment. And that is very important. These things are basics, but if we jump over these, then later on we have to pay the price for this. Similarly, on the hemodialysis center, anyone touching the patient, especially their access, they need to wash their hands, have gloves, have personal protective equipment. These things the medical directors enforce. There are several layers of oversight on dialysis centers. So if some dialysis center is not doing well, the ESRD network may come in and check on them and make sure that every protocol is being followed correctly. Like I mentioned, in a dialysis unit, you may have several patients in a shift. Some of them may have a communicable disease or infection with a superbug, a multi-drug resistant organism. And so the medical directors would enforce what are known as modified contact precautions so that those patients are jumbled together at one end and they are sort of isolated from the rest of the dialysis shift. And then one of the most important things to risk mitigate is to appropriately vaccinate against common culprit organisms. So vaccination for the flu, and this year's flu season that we just had was one of the deadliest in several years that we have seen. So this year's flu is probably going to be just as bad. So please get your flu shot. COVID vaccination boosters, very important. Vaccination for hepatitis B virus. It's a blood-borne viral illness. But if you've got appropriate vaccination for hepatitis B done and you've got the appropriate antibody titer detectable in your bloodstream, your risk of catching hepatitis B drops precipitously. Vaccination for pneumococcus, one of the pneumonia bugs, very important. In the appropriate patient, vaccination for shingles. As time goes by, we tend to lose some of the immunity against tetanus, diphtheria, pertussis, etc. So your physicians would be checking for those antibodies and if needed, giving you boosters for some of these illnesses as well. Now, as I go on to the vaccination list, it's important to get vaccinated before you get transplanted, because as Dr. Paul will talk in a little bit, once you've gotten transplanted, there are certain types of vaccines that we don't want to use because in the transplant scenario, you've got immunosuppressive medicines on board, and that leads to some concerns. With peritoneal dialysis, one of the major infection risks is peritoneal dialysis-associated peritonitis, which can be mitigated by appropriate exit site care and your peritoneal dialysis nurses, as they are training you for peritoneal dialysis, will teach you how to take care of the exit site. Exit site is where the catheter comes out of the belly, and they will train you how to make the connection. That's very important, and doing it every time is very important in a sterile fashion. Now, not to belittle this, anybody can make a mistake, but I had one patient who was having some difficulty with drainage of the PD fluid, and they took the end of the catheter in their mouth and they tried to blow into it to clean it up, and they had bugs in the peritoneum that my pathologist called me, "What are you doing with this patient?" And then we had to figure out, how did those bugs get into the belly? And that's where that was coming from. So we just have to make sure that we follow and adhere to our protocols as closely as possible. And then your PD nurses will teach you how to identify symptoms of an infection in the belly early, and have mitigation strategies where you can start treating as well as getting help on a very, very expedited basis. So this is a complicated scenario. Our patients are very vulnerable. They are in environments that make them very vulnerable to various different types of infection. So the best thing to do is to build the ark before it starts raining. So when you've got chronic kidney disease and you're moving towards advanced stage chronic kidney disease, that is the time to have the conversation with your nephrologist about the appropriate access and timing of placement of access, appropriate and expeditious referral for transplantation evaluation so that we can get you transplanted, and completion of all necessary vaccination so that we are decking the stack in your favor before you have those exposures, which unfortunately we know shall happen when you're in those compromising environments. With this, I will stop, and I don't know if Dr. Paul's going first, or are we having questions, if there are any. I'm okay with either.
Thank you, Dr. Agha. Now I'd like to welcome to the podium Dr. Paul to lead us through infection prevention strategies in transplant patients.
So good afternoon, and I want to thank the AAKP, all the organizers, Erin for the very kind introduction, and Dr. Agha for his very kind words. And I also want to particularly thank Ms. Diana Kleins and Mr. Paul Conway for the gracious invitation. And of course, to thank all of our patients and advocates. Without your support, things like this, gatherings like this wouldn't even be possible. So today I'll be talking on the same topic as Dr. Agha, but with a focus particularly on kidney transplant candidates and kidney transplant recipients. And as you'll gather, that it's the same concept, but it's a very different ball game to being on either hemodialysis or peritoneal dialysis. So when I was asked to give this talk, it actually reminded me of an interaction that I had with one of my patients a couple of years ago, shortly after the height of the pandemic. And basically it was a gentleman that came in with his wife, and they had a loved one who was very sick with COVID. The patient was doing very well. He was within his first 12 months of transplant. Kidney was working nicely. He was tolerating his medications, but he was understandably concerned about the risk of getting an infection himself. Both of them were. And as I was talking to them, I realized that the anxiety was not simply the risk of infection. The anxiety was about the plethora of information that was around them 24/7. You literally had to turn on the TV, watch the news, go on social media, and there were all sorts of messages, opinions about what you should and should not be doing during the pandemic. And there were certainly a lot of opinions in that household. I could tell very quickly that it was a very politically diverse household. They had a lot of interesting conversations at their dining room table about, whether you should wear masks, whether you shouldn't, whether you should vaccinate, whether you shouldn't. They literally felt confused and paralyzed. They just didn't know what to do, and to a large extent, I think they didn't even trust some of the medical advice that they were getting from other providers. So I was quite honored that they were asking for my take on it. And what I realized in that encounter, and it's along the lines of what Dr. Janice Lee alluded to and what Ms. Lisa Custer alluded to, which is that need for an individual conversation with a patient and family. Because when you think about it, any concern is a valid concern. It's very easy and escalatory to say, okay, something you read on social media is fake news or misinformation, even if that is your own personal opinion. But if it's a concern someone brings into the office, you have to listen to that concern. And it's listening and learning about what a patient feels and is keeping them up at night. And it becomes a two-way street. As a patient, it's an opportunity to learn about what resources are available at your disposal to stay safe. And that's the key word, I think, for the rest of the talk, which is that everything I'm presenting is literally just a collection of resources that you have at your fingertips to guard yourself against getting an infection. And with that, I don't have any disclosures for this talk, but we'll start off with why infection even matters. The fact is infections are common. And after transplant, infections can even be quite dangerous. They can land you up in hospital, they can land you up on dialysis if it's a severe infection, and it can even threaten your life if it's a severe infection. And while it may seem that having to or trying to avoid getting infected seems like social avoidance, withdrawing from social life, crawling under a rock, it's far from anything like that. If anything, infection prevention is about being proactive and taking strategies as a first step or as the first move so that you can live life with confidence and do the things that you pursue transplant for, whether it be to go back to school, go back to work, to spend more time with family or friends, travel, whatever have you. And it entails preventing or protecting oneself from common infections that can infect any one of us, including me, who's not on immunosuppression, or very specific things that are specific to transplant individuals. And the bottom line is to do this so that you can live a quality of life and not simply live with a transplant but thrive after a transplant. What's the burden and spectrum of these infections? Basically, they're the most common in the first 3 to 6 months, even up to the first year after transplant. And that's because the immunosuppression is most potent in that first year. You get given what's called induction immunosuppression when you first get when you have your surgery. And that risk doesn't dissipate completely. It persists lifelong because you're on lifelong immunosuppression. And this can range from bacterial infections such as UTIs, pneumonias, and viral infections such as COVID, such as influenza, and even certain fungal infections, which are not common but can occur. And the reason why people are at risk, and I alluded to it already, is basically immunosuppression. That's the big elephant in the room. Yes, there are other factors that play into this, but immunosuppression plays a big part of it. And as I mentioned, it's highest early on after transplant, but it persists lifelong because you're going to be on immunosuppression lifelong. And other risk factors that you may have had prior to your transplant may also put you at risk, such as underlying diabetes, cardiovascular disease, or obesity. So the overall outcome or the net effect is that you are at greater risk than the general population. So how do we prevent this? So basically there are two pillars or a two-armed approach that we can pursue. The first thing is taking everyday precautions to help keep yourself safe, and I've got some slides on this towards the end. And the other big part of it, and this is going to be the bulk of my talk, which is about using vaccinations as a tool to prevent these infections. Now, these two approaches are complementary. They're not substitutes for one another. And if you are able to leverage each of them to your full ability or to the extent that you feel comfortable with, that'll render you the best protection. So I'm going to start off with vaccinations first. And I'm just going to stop for a minute and just go back to what I said initially, remembering that vaccinations are always a resource and it's always worthy of a conversation. So if you have concerns, if you read something on social media that made you feel anxious about it, bring it up with your provider. Don't feel that you're going to be shot down or that someone's going to dismiss your concerns. As Dr. Lee even said, if you get a reaction where you feel that your interaction with your provider is not really landing the way you want it to, or you feel that your concerns are being dismissed, or you're being badged in a way that you don't think is fair, then maybe you need to discuss that with a different individual. And on the same token, you're there to teach your provider what matters to you and what concerns you. You're also there to learn from them and learn what the benefits and risks are of vaccination. And if you do leave the office declining a vaccine, even if that was recommended by the provider, the important thing is that you understand what the risks are of taking that decision. That's what's most important. It's that knowledge and that insight. So just a bit of an overview. I'm going to talk about vaccination strategy first, then we'll talk about vaccination safety, and then a summary of the key vaccines. So ideally, when to start vaccination, it's ideal pre-transplant. And Dr. Agha also mentioned this, because you're going to have a stronger immune response if you can get vaccinated prior to your transplant. You can also get live vaccines prior to your transplant, which you cannot get afterwards. It also makes things logistically more simple if you're vaccinated from the front end, rather than having to catch up with vaccination schedules afterwards. And it's also going to render you better long-term protection if you can do it this way. But with that said, let's say you were put on the transplant wait list, you got that organ offer a lot quicker than you expected, or for whatever reason, you never did the prior vaccine series, you never completed the vaccine series, or you were not interested in vaccine before, but here you are now 2 years after transplant and you feel that you should be vaccinated. That is still okay. You can still get vaccinated to render you some protection, but there are some caveats. The first thing is that vaccination is typically postponed by 3 to 6, sometimes 12 months after your surgery, because your immune system is not as robust to mount an immune response. We want to avoid live vaccines, as Dr. Agha also mentioned, and we do need to check some serologies, such as for hepatitis B, to make sure that you mounted an adequate immune response. And the only exception to the 3 to 6 month rule is influenza, which can be given even as early as 1 month after transplant if we're in the midst of a flu season, which we are now. So in terms of safety, very fair concern, and there's very fair data on it as well. The general consensus is that inactivated vaccines are safe after kidney transplant. Live vaccines are not, so you should not accept a live vaccine after you get your transplant surgery. Household members ideally should also be vaccinated to inactivated vaccines, and I've got a slide on this towards the end as well. But the point I'm going to make here is that there are certain live vaccines that even household members should not receive, because live vaccines are essentially live virus, which can shed in the mucous membranes and infect people around them, including you, if you happen to live with someone who got that vaccine. And so starting off with the influenza vaccine, so very common, it's called flu season for a reason. There's a high-dose vaccine which is recommended if you have had a kidney transplant. They do recommend getting the inactivated vaccine, obviously not the live intranasal vaccine because it's a live vaccine. And there's data to show that it reduces pneumonia, it reduces ICU admissions and hospitalization if you do get vaccinated against the flu, so it will be beneficial for you. And as I mentioned, household members, if they can get it from their health perspective, they should also get vaccinated against the flu. Then pneumococcus. So the pneumococcal vaccine is also recommended per the ACIP for all adults, anyone over the age of 19. There are various schedules for getting the pneumococcal vaccine, and it does get a little bit confusing. The most typical schedule is getting a conjugate vaccine first, then followed by a polysaccharide vaccine, but it doesn't have to be that way. And also, you may have had an older type of pneumococcal vaccine that might mean that your schedule needs to be different. You're not expected to know what schedule you're supposed to be on. If you've had a pneumococcal vaccine before, talk to your transplant team about your prior vaccination records if you've got them, and they can tell you how to complete the pneumococcal series. And although the antibody response is weaker, and I get asked about this, well, why the heck should I get the vaccine if the antibody response is going to be weaker? Why put up with the side effects of the vaccine if there's not going to be any benefit? It's a good question, but the answer is that there is benefit. And even though it's a smaller immune response, it's still clinically meaningful. And the other thing to be said about pneumococcus is that not only does it cause pneumonia, it can also cause a blood infection, and it can even cause meningitis. So you're protecting yourself against 3 diseases, not 1. And Hep B, as Dr. Agha also said, everyone who's a candidate should get it. Everyone who's a recipient should also be vaccinated against Hep B. Not only does that protect you from Hep B as a virus, it also protects you from long-term cirrhosis and long-term liver cancer that can occur in people with hepatitis. And for this as well, there's a high-dose vaccine which is recommended because it gives a stronger immune response. We do check serologies. Serologies means checking your immune response after you get the vaccine to make sure that the vaccine worked. And in hepatitis B, you would be eligible for another vaccine if your immune response was not adequate. Hepatitis A is less talked about in the US for good reason, because this isn't an endemic area. But if you're from an endemic area, getting your transplant in the US and going back to your home country, or if you're planning a holiday or a vacation to a place where Hep A would be endemic and you aren't immune, this is something to be talking to your team about getting vaccinated against. In a perfect world, if you can work with a travel medicine clinic to work in partnership with your transplant medicine clinic to come up with an appropriate vaccination plan for you, that's the best way to proceed, because then they can give you a vaccination plan that's specific for your intended travel. And there are even some other conditions like clotting disorders or liver disease where getting the Hep A vaccine is prudent. And the response may wane with time, which is why we do suggest checking serologies and giving another Hep A vaccine if you think you're going to be at exposure or if you're going to be at risk again, such as if you're planning trips back and forth between that same area. HPV is human papillomavirus. A lot of you would be familiar with that in the context of cervical cancer in women. It can also cause anogenital cancers in both genders. Transplant patients do have a significantly higher risk, but it is more associated with age and behaviors. So it's not recommended in everyone with a kidney transplant. It is recommended for younger pediatric transplant recipients. For the ages of 27 and 45, the CDC recommends having an individual conversation with your transplant provider. And there is a very potent 9-valent vaccine that's available that can protect against some of the cancer-causing strains. We want to start this before transplant, if possible. But if we have to give it post-transplant, we can. The caveat is that you might need 3 doses instead of 2, just because of that immune response issue. Then shingles. So very common, happens to a lot of people. A few years ago, there was not a way to safely immunize people against shingles, because kidney transplant patients, that is, because the shingles vaccine was a live vaccine. Fortunately, we now have an inactivated vaccine, which transplant recipients can safely get. It's a 2-part vaccine which protects you not only against shingles, it also protects you from the nerve pain that comes with shingles if you still contract shingles. It also reduces the length of illness if you are unfortunate enough to get shingles. Quite understandably, patients come to me feeling very demoralized. They did all their vaccinations, they completed the Shingrix series, and yet they've still got shingles. I always reassure them that it's good that you got the vaccine, because you're going to have less nerve pain, and you're going to have a shorter duration of illness because you got vaccinated. And like I was saying, the live vaccine is contraindicated. Fortunately, the live vaccine is no longer available in the US, but you should still get in the habit of asking whoever's giving you a vaccine, just as a final check, make sure you're not giving me a live vaccine. And certainly if you are planning to move abroad, in some countries they do use the live vaccine, so it's always a good habit to ask. RSV caught a lot of interest in the last few years when there was an increased number of cases. There is some conflicting or some difference in guidelines as to what an appropriate age bracket is appropriate. It's not a huge difference. One consensus guideline says between 50 and 74, another one says between 60 and 74. Both say you should get it after 75. Talk to your transplant program about what age bracket applies to you. And it's particularly important in people who have chronic lung disease, in people who have frequent child exposure, such as daycare workers, people that work in elementary schools, things of that nature. It's also very effective in reducing the badness that can come with getting an RSV infection. I will mention that there have been case reports of GBS or Guillain-Barré syndrome. This is a rare neurologic syndrome that has been reported only in the form of case reports after the vaccination. On population-based studies, there is no increased risk. In other words, all things being equal, your risk of getting GBS from the RSV vaccine is no higher than if you were to get placebo. With that being said, if you have a personal history of Guillain-Barré syndrome, or if you've ever had anything that mimicked a syndrome like GBS in the past, make sure you bring that up with your provider before you accept the vaccine. Then the one that we're all too familiar with, COVID-19. So by now there's a whole plethora, a whole library of data showing that people with COVID-19 who've had a kidney transplant don't do as well. That's why the vaccine is recommended for all transplant recipients as well as the general public. There is different forms of the vaccine, the mRNA vaccine, the protein vaccine, there's even an adenovirus vector vaccine. Each one has its pros and cons in the general population. As far as kidney transplant is concerned, the pendulum is more in favor of the mRNA vaccine. But if you're not comfortable getting the mRNA vaccine, or if you've had a problem with that in the past, you can get the protein vaccine as an alternative. All of them are still effective. Immune response may not be as strong as a non-transplant recipient, but it's still clinically meaningful. And if you simply cannot tolerate vaccines, there is the option of having a monoclonal antibody given to you in advance of an infection to try and mitigate it. The caveat is that different monoclonal antibodies will respond or will mitigate different strains. So there are some strains that have become resistant to Evusheld. You may recall that was on the market for a few years. That's one that's less efficacious now. Pemivard is still effective, but again, you should talk with your provider to find the right one for you. And there was a lot of concern about, is the COVID vaccine safe in kidney transplant recipients? And there is data that it indeed is. In the interest of time, I'm not going to dwell too much on the other vaccines, just to point out that they do recommend getting the Tdap vaccine, not for the measles, mumps, and rubella or the varicella vaccines, because these are live vaccines. The meningococcal vaccine is appropriate if you're on something called a complement inhibitor. And then travel vaccines we've talked about, and that should generally be done in partnership with a travel medicine clinic if possible. Taking this concept one step further, we've been talking about vaccinating the recipient. There is this concept from pediatrics which involves vaccinating people who live around the child or live around the index patient. If your household members or people that frequently visit your house, like a caregiver, can also be vaccinated, that will also give you a layer of protection as a kidney transplant recipient. So this applies to influenza and COVID-19 certainly, but the live vaccines, some of the live vaccines, there are problems. For instance, people should avoid coming into contact with someone who's had the oral polio vaccine, the smallpox vaccine, the live intranasal influenza vaccine, or the rotavirus vaccine for a baby. If you find yourself in that situation, that other co-resident who lives with you should talk to their provider about whether they really need the live vaccine or whether they can get by with an inactivated vaccine. Now, let's say your child is in the military, they need the smallpox vaccine for duty, then in that case, there has to be some discussion about what would be a safe quarantine period that you could stay away from your child after they get the vaccine so they don't inadvertently infect you. So I'm going to switch gears a little bit and talk about everyday prevention, and in the interest of time, I will keep this brief. And I think this is something most people in this audience are quite familiar with, certainly if you've been through the dialysis journey, and even after getting a kidney transplant, a lot of people ask questions about what they can do to stay safe, and things like hand hygiene and masking is something that is quite deeply ingrained. But I think where people struggle a little bit is those situations where you're in a scenario where people around you don't necessarily think like you in terms of what's a safe hygiene practice, such as you get on a plane, there are children around you coughing and sneezing, and then you have to reach down to your bag to put on a mask. The thing to be said about that is that there is some clinical data that shows that these strategies are safe and effective, and you can use medical advice as a reason to mention to other people, and usually people are very understanding if you're saying that you're doing something upon instruction from your nephrologist, your transplant nurse or what have you. So with that said, there's a lot of data that hand hygiene is very effective. It reduces the transmission of infections. There was also data during the COVID pandemic that masks might be effective. And then food. And I'm sorry to show you a slide like this so close to lunch, but basically your transplant dietitian is an immense resource to discuss individual restrictions on what you can and cannot eat. Hopefully after your transplant you have a lot fewer restrictions than you need when you're on dialysis. But as far as safety is concerned, avoiding things that are raw, not properly cooked, unpasteurized milk or honey, raw sprouts, those are the things that you want to avoid. And if you are invited to a buffet, you do have to politely advise the host that, look, you have been told not to eat from a buffet. The food may be appropriately prepared, but you don't know who's going to be cross-contaminating it. And if you are ordering from a menu, it's very appropriate to ask your server to talk to the chef about whether your dish can be modified or ask questions about it to make sure that it is safe for you to consume. And then taking it home, practicing safe food hygiene at home is critical, safe food preparation, safe food storage, and then taking it beyond the kitchen as well, avoiding high-risk activities such as gardening without gloves, cleaning bird cages, cleaning cat litter. If you are a bit of a green thumb and really want to get back into the garden, you have to talk with your transplant team about whether that's permitted for you. And certainly if you are allowed to do that, you probably should be wearing gloves. And everything I've talked about is prevention, but prevention is not bulletproof. I mean, people do get infected even after they get vaccinated. And the important thing to be said here, and this is my second to last slide, is that it's important to recognize the signs of an early infection. If you start to notice that your temperature is a little bit higher than usual, maybe a bit lower than usual, you're feeling fatigued, under the weather, that's your signal to pick up the phone and call your transplant coordinator. There are no prizes for false alarms, but there's certainly no prizes for bravery in transplant either. You're better off seeking attention early rather than making assumptions and then getting sicker and putting yourself at risk. So with that, the main closing points, I think I've emphasized the importance of recognizing infections as a risk factor after transplant. I think understanding that vaccination is a tool and it's always there for you to use and exploit to your own personal advantage, with all due respects to what you hear in the news and in media. Everyday habits do go a long way in mitigating infections, and early recognition is also key in this endeavor. And something I haven't mentioned in this slide deck is that maintaining close communication with your transplant team is also always prudent, because it's very hard to contextually give a person advice if you haven't seen or heard from them for like 5-10 years, as opposed to someone who regularly gets lab work, regularly keeps in contact with their transplant coordinator, and has a good line of communication with other transplant personnel as well. So I'll thank you so much for your attention, and I think we'll be having time for questions. Thank you.
Thank you, Dr. Paul. Before we conclude, I do have one question that I'd like to pose to both of our speakers. Many patients worry about infection risk, not just in the hospital, but in their day-to-day lives, at work, at school, at the grocery store. From your perspective, what's the single most important habit or strategy that patients can do starting today to reduce their risk of infection, regardless of what modality of treatment they're on?
Hand washing. Frequent hand washing, hand sanitizing.
Hand washing?
Yeah, I completely agree with Dr. Agha, and I think if I was going to add to that is awareness. Know how things are being cleaned around you. If you hear that someone is sick, you hear someone coughing and sneezing, have hand sanitizer, have masks available, and because sometimes you're caught by surprise, like you go to the airport and then the person next to you puts something on your tray and clearly it's not hygienic. It's always handy to be traveling with hand sanitizer and other things, or Clorox to disinfect surfaces when you need to.
Does Lysol wipes?
Lysol
or
wipes, yeah.
Clorox
Beg your
wipes?
pardon, yeah.
Great. Well, thank you both so much. That was a very informative presentation. So that's all the time we have for this session. I'd like to again thank Dr. Agha, Dr. Paul, for sharing their time and expertise with us.